Vaccine Essential Series, brought to you by Rutgers, Robert Wood Johnson Medical School, the New Jersey Department of Health, and the Nicholson Foundation. We know you need this important information, and we are here to answer your questions and address your concerns. My name is Mary Bridgman. I'm a clinical professor at the Ernest Mario School of Pharmacy at Rutgers University and a clinical pharmacist at Robert Wood Johnson University Hospital in New Brunswick, and I'll be facilitating this morning's discussion. For anyone new to Project ECHO, the rapidly evolving situation with COVID-19 necessitates a responsive, fluid, and interactive communication strategy with the fast-track rollout of the vaccines for healthcare workers and long-term care residents in particular. These sessions have been designed to answer your questions and to provide you with the latest information on the vaccine rollout plan. The purpose for today's session will be to provide you with an overview of what to expect when becoming vaccinated. In today's session, we'll be hearing from members of the New Jersey Department of Health to learn more about this important aspect of the vaccine rollout, which is already well underway, as I'm sure you're aware. We appreciate all of the questions that you've submitted upon your registration. You can also submit questions using the Q&A feature in Zoom during our presentation, and I would welcome our participants and panelists to respond to those in real time. We are sensitive to the urgency of your requests, and I promise we will make an attempt to answer as many of the pre-submitted and questions submitted during the session as we possibly can. This session is also being recorded, and it will be accessible within 24 to 48 hours after our session on the Rutgers Project ECHO COVID-19 website. This website also includes links and resources that may be shared today, as well as a recording from the session. And then finally, as the timeliness of this content changes with each passing day, if you are viewing this recording at a later time, realize that this may not be the most current information at the time you are viewing it. Note that information and websites for the New Jersey Department of Health, the CDC, and covid19.nj.gov as resources for healthcare providers are provided on the flyer and will be redistributed after today's call. To begin with, I wanted to introduce Dr. Meg Fisher, a pediatric infectious diseases physician who will be providing greetings from the New Jersey Department of Health. Dr. Fisher, thank you for being here during such a busy time for the department. I know I speak on behalf of everyone joining the call, just how much we appreciate your participation and support for these sessions to address the many questions that exist surrounding vaccination.
Well, it's a pleasure for me to be on the call, and I hope I also get to introduce our speaker. And if it's okay with you, we'll get right to that.
Sure.
So I'm delighted to introduce Eddie Bresniff, the person who knows the most about public health, COVID-19, COVID vaccines, and just about anything else that you can think about. He's come out of a retirement to rejoin the New Jersey Department of Health as a medical advisor. And as you know, he was a former commissioner of health here in New Jersey. And he's going to talk to us about the COVID-19 vaccines, specifically the mRNA vaccines. And without further ado, I'm going to let him get to his talk because I know it's worth listening to. Thank you.
Well, I'm just going to wait till you switch off to. We're going to change the view.
If we can pull up Dr. Bresniff's slides.
So Meg, thanks for that generous introduction. I mean, you've set a high bar for me. And I was not the commissioner of health. I was a deputy commissioner in the past. And I don't, which is elevating me to probably a level that I never wanted to be. But thanks anyway for that. And good morning to everyone, and welcome, and thank you for taking time out of your busy schedules to basically listen and participate in this presentation. Last week, actually, it seems like a long time ago, but last Friday I made a presentation focusing on the data from Pfizer on their phase 3 trial, looking at efficacy and safety of their vaccine. This was actually before it was, the FDA issued an emergency use authorization for its use, and before ACIP weighed in on its recommendations, and before vaccine began to be distributed and used in the state. So I'm going to refer you back to that particular presentation for more detailed data about the Pfizer product, the Pfizer vaccine. Yesterday at the FDA, the vaccine related biological professional advisory committee that advises the FDA on vaccines met and voted 20-0 with one abstention to recommend to the FDA that they issue an emergency use authorization for the Mrna vaccine. And if you're interested in a lot of detail, you should go to the FDA website. The presentations that were made both by Pfizer and Mrna, as well as the FDA, are on that site, and you can go through a lot more detail than I either presented last week or that I'm going to talk about today. I'm not going to spend a lot of time on the Mrna data. I'm going to say right up front that it's fairly equivalent to the Pfizer data in terms, because it's the same mRNA platform. And with that, I'd like you to advance to the next slide, please. Next slide. So both platforms are what are called, are using a technology where messenger RNA is the vehicle by which the genetic code is introduced into the cell of the host, the patient. And then the cell basically produces protein. In this case, it's the spike protein of the coronavirus. And that spike protein is the specific target antigen that the body reacts to when there's an immunologic response to the vaccine. And this particular protein basically will block the spike antigen, which facilitates the entry of the virus into the cell during an infectious process. Next slide, please. And from a schematic perspective, this is a slide on nucleic acid vaccines. I just want you to focus in on the bottom on RNA vaccines. I'm not going to talk about DNA vaccines. There are no DNA vaccines at the moment. So the RNA vaccines, both the Mrna and the Pfizer vaccines, are not live vaccines. What happens is that there's a piece of the genetic code that codes for the spike protein. It's encased in an envelope of a lipoprotein, a nanoparticle, lipoprotein nanoparticle. And then that particular, once it's injected into an individual, that particular nanoparticle attaches to the cell. The viral genome is released into the cell. Then basically the viral proteins are made within the cell, not in the nucleus, but in the cytoplasm. And then those viral proteins are released. They're taken up by that cell on the right, which is an antigen presenting cell. That's a cell that facilitates the presenting of the viral protein to the immunologic system, both T and B cells. And we get a T cell response and a B cell response, both immediate. And then there are memory cells that are also produced as well. And those memory cells will become important as time goes on. And there's a potential for some waning of the serologic response in the serum. Next slide, please. And so next few slides, what I'm going to do is I'm going to compare the characteristics of the two vaccines. Again, they're very similar vaccines, the same technological platform. And this is the first time that actually vaccines have been produced using this particular technology. So we have on the left-hand side some of the characteristics that we're going to talk about. In the middle, we have the BioNTech with Pfizer vaccine. The emergency use authorization was issued last Friday, and the Mrna vaccine is on the right. We're expecting the EUA to be issued any time now today. And then tomorrow, the Advisory Committee on Immunization Practices that advises the CDC will be meeting to go over the Mrna data and make a recommendation to the CDC about how that vaccine should be used. So let's go through these next slides. So, and contrast the two vaccines. Even though they're the same platform, the same not yet, sorry. Even though they're the same platform, let's go through the dosing regimen. So clearly there's a difference. The Pfizer vaccine is given at day 0, that's the first day, and then 21 days later. And there's a time interval there. You can give it as little as 17 days and then any time after 21 days, but it's advised to give it at 21 days if possible. And then the Mrna vaccine is at 0 and 28 days. And Mrna just typically, their research study using other mRNA, other vaccine research has always focused on giving it at 28 days versus 21 days, but there's no real difference. There is a difference in the packaging or the formulation. The Pfizer vaccine is a frozen liquid. a 5-dose vial, and under its storage conditions are skipping down, is ultra cold. It's minus 60 to 80 degrees centigrade. Here it's the average of minus 70. And then when you take it out of the ultra cold storage, you can be refrigerated in the regular refrigerator for 5 days, not more. And then once it's diluted, because it requires dilution, it requires injection of sodium chloride, saline, to basically produce the volume that you need. And you can get approximately 5 doses out of the vial, but there's some recent information that suggests that you can get 6 and as many as 7 doses out of a particular vial, just because of the volume of the diluent that's introduced into the vaccine. And it's also dependent on the size of the needle that you use as well to withdraw the volume out of the reconstituted vaccine. On the Moderna side, it does not require diluent, and it's also frozen liquid, but it's a 10-dose vial, also preservative-free. And its storage requirements are a little bit more forgiving. It can be shipped at minus 20 degrees centigrade. Same type of refrigeration process. Both can be kept at their particular storage level for 6 months. Once you take it out of the freezer, you can refrigerate it for 30 days as opposed to 5 days for the Pfizer vaccine. And you have to use it within 12 hours of thawing it as opposed to 6 hours of diluting the Pfizer vaccine. So there are differences between the two. And the chemistry, manufacturing control data submitted to the FDA were adequate to allow for emergency use authorization. Next slide, please. So this gives you a little bit data about the results of the trial. You can see on the top the number of people who were enrolled in the study. The Pfizer product actually looked at individuals 16 and over. And so the EUA for the Pfizer products, it can be used in those 16 and over. The Moderna product, once the EUA is available, will be for 18 and over. The overall efficacy of both vaccines were almost exactly the same. The Pfizer vaccine was 95%, and they began, and that's beginning 7 days after the second dose. The Moderna vaccine was 94.1%, and again, that's starting 14 days after the second dose. So the two manufacturers decided to collect cases a little bit differently after the second dose. In one case, it was 1 week, and the other case, it was 2 weeks. And you can see the number of people who actually had COVID-19, 8 in the vaccinated arm and 162 in the control arm, and 11 for Pfizer vaccine, 11 in the Moderna, in the vaccinated arm in the Moderna product, and 185 in the control arm. So quite a difference. If you look at some of the sort of subgroup characteristics, you can see that in the older and then younger populations, vaccine efficacy was about the same, over 93, 95% for the BioNTech Pfizer vaccine in the 56 plus versus 16 to 55. And in the 65 and over for the Moderna, it was a little bit lower, but the 95% confidence interval overlapped with the overall efficacy. So it's probably not statistically significant. And when you looked at various subgroups, racial, ethnic, comorbidities, gender, the vaccine efficacy point estimates were approximately the same. They also had secondary analyses where they looked at severe disease. Severe disease was defined approximately the same in the two studies. For example, if people were hospitalized with COVID-19, or they were in an ICU or on a ventilator, or they had O2 saturation to drop below 93%, those are considered severe cases. And vaccine efficacy for the two studies, again, were quite significant. 89% in the Pfizer, with the Pfizer vaccine, although there were not a lot of cases, and then 100% with the Moderna vaccine, although they now have one case that's being evaluated in the placebo group, so it may not be quite 100%. And then they also looked at what vaccine efficacy was after the first dose. Before the people got the second dose, there were a number of COVID-19 cases in both studies that occurred between the first and second dose, so they were able to assess efficacy in the trials. And you can see that in the Pfizer study, 52%, there was a 52% efficacy after the first dose before the second dose was given. And in the Moderna study, it was 80%. And again, the curves looking at the number of events in the two groups began to diverge around 2 weeks after the second dose. So, and they also had a number of patients in the studies who were COVID positive, actually before they got the first dose. They didn't exclude those patients from the subjects from the study. They went ahead and vaccinated in any case, and that's important. I'll come back to that later on when we're talking about clinical considerations. But you can see here that even those who had previous COVID-19 infection, there was no issue with vaccine efficacy in those individuals. So next slide, please. Looking at, so in order for any company to submit a application for emergency use authorization for COVID-19 vaccine, the FDA requires them to have at least 2 months of follow-up in a median of 50% of the study subjects. And so the Pfizer folks had approximately 38,000 individuals who met that, that requirement. And the Mrna group had almost 30,000 in that group. So they met the requirement for submission of the EUA. And I should add that this is an EUA. So this is an emergency use authorization. These are they are not licensed vaccines. The EUA is exactly that. It's an authorization to use the vaccine when the risks outweigh the benefits outweigh the risks. And there's no alternative for the intended use. In this case, is preventing disease. And even though there's a Pfizer EUA now, since it's not approved, this still allows the Mrna vaccine to be used under an emergency use authorization. So when you talk about these vaccines, you can't say that they've been approved. They've been authorized for use under the requirements of the law that allows for emergency use authorization of any biological product, whether it's a vaccine or otherwise. Looking at the safety issues, looking at the common AEs, these were quite, local injection site reactions were the most common. Over 80% of individuals with both vaccines had injection site reactions, either mostly pain, but there was swelling and erythema and tenderness as well. And the percentages for each of those symptoms or signs varied. And then when you looked at systemic reactions, you can see here that they were about equivalent across the 2 products, except maybe for muscle pain and joint pain, which seems to be more with the Mrna product. These were, by the way, these were adverse events that were solicited adverse events within the first 7 days after vaccination. And they were similar across the various demographic subgroups, such as age and gender and ethnic and racial characteristics and comorbidities as well. These reactions were mostly mild to moderate in nature and most frequently occurred the day after the injection and resolved on their own or with antipyretics if individuals had a fever. There were very few grade 3 reactions, where there was some interference with an activity of daily living. And it turned out that older individuals were less likely to have these reactions than younger individuals. And also, however, both groups, younger and older, tended to have more significant reactions after the second dose. So the first dose doesn't protect you from having reactions the second time around. In fact, they might even be a little bit worse. But again, mild to moderate in nature, resolved, mostly occurring in the second day and resolved within a couple of days. Next slide, please. So when you look at serious adverse events, both of them basically had some serious adverse events. Again, these were things like, a hospitalization, for example, might be a serious adverse event. Again, they were pretty balanced in both groups. There were no imbalances actually between the study arms. So serious adverse events were essentially the same in both the Pfizer studies and the Pfizer study and the Mrna study, whether they were in the placebo group or whether they were in the control group. And these tended to be more frequent after the second dose versus the first dose. There were some deaths in both studies, but they were balanced between the 2 arms of the study. So they didn't appear to be related to the vaccine. What was a notable finding actually in both studies was several instances of Bell's palsy, which is a facial paralysis. and some of the comments at the various FDA meetings and the CDC meetings seem to state that this was what could have been expected within from an incidence perspective in the background population. And I should say, by the way, there's an error here on the Mrna side. There was actually one case in the control group, not 0 cases. But it's a little bit interesting to see that actually in both studies using the same technological platform, there were some people who had this Bell's palsy. Bell's palsy is usually transient and resolves on its own. Occasionally, people may be left with a partial facial paresis. And that's going to be continued to be followed in the post-EUA safety follow-up. In fact, it's going to be required of the manufacturers. And I'm going to get to anaphylactic and hypersensitivity reactions later on. Next slide, please. Okay, so now I'm going to go through some clinical considerations that were made by the Advisory Committee on Immunization Practices and the CDC last weekend. These were published in the Morbidity Mortality Weekly Review or on the CDC website. There was a publication on the website, and the references are on the bottom here. Most of what I'm going to talk about now relate to the Pfizer vaccine because there hasn't been a meeting yet of the ACIP to consider the Mrna data and to issue a recommendation on that. But a lot of what I'm going to talk about will also probably apply to the Mrna vaccine as well. I mean, I don't want to say 100% that's the case, but since they're such similar vaccines, it's likely that the clinical considerations for the Pfizer vaccine will apply also to the Mrna vaccine, but we'll see. Next slide, please. So ACIP met on December 12th and recommended the use of this vaccine for those 16 and over under the FDA's emergency use authorization. And they also recommended that healthcare personnel and residents of long-term care facilities be offered the vaccine in the initial phase 1A. And that's what started this week, right here in New Jersey. And you saw lots of coverage of that in the media. And that occurred because of the FDA EUA and the ACIP and recommendations and the CDC guidance. And as you see, tomorrow, the ACIP will meeting to consider the Mrna vaccine. Next. Next. So it's a 2-dose series. In this case, the Pfizer vaccine is 3 weeks apart. Remember, the Mrna vaccine will be 4 days apart. I mentioned the grace period. If the vaccine happens to be given 3 or 4 days before the 21-day period, it'll count. If it's given before that, it won't count. And that's important. That's true for most vaccines. There's a grace period. If it's given any time on the 21st day or after, it will count. In the study trials, some individuals got the vaccine up to 6 weeks after the initial dose, but that's still a count. It doesn't mean that the series has to start over. And that's indicated here on the third bullet. Both doses are necessary for protection, even though I showed you that a single dose can result in some vaccine efficacy, but that's basically a secondary sort of analysis, and I would not recommend that individuals get 1 dose and think that they might be protected. And we also don't know the durability of that dose, nor do we know the durability of the second dose as well. Next. The recommendation is that you get vaccinated with the same product. You shouldn't get one product and then get the other one. They're not really interchangeable for the simple reason that they haven't been evaluated for either efficacy or safety of using a mixed series. On the other hand, the recommendation from the CDC or the guidance from the CDC is that if an individual inadvertently happens to get a different vaccine on the second dose, that basically they should not get a third dose of either vaccine, that basically they should consider that their series is completed. A lot of guidance is being provided to providers around the state to ensure that, in fact, this doesn't happen, but sometimes mistakes are made. Next slide, please. Frequent question is giving this vaccine with other vaccines, as we might get, for example, with the flu vaccine and pneumococcal vaccine, or the flu vaccine with the zoster vaccine. Neither of these manufacturers studied their COVID-19 vaccines with co-administration of any other vaccine. So it's not recommended that if a person comes in for one vaccine that they get a second shot with a vaccine that they might be eligible, like flu or pneumococcal vaccine or the zoster vaccine. That really should be, they should really wait to get vaccine. Either they should get it 14 days or more before they come in for their first dose of the COVID vaccine, or 2 weeks after they get the second dose. Next slide. Next slide. So what about if an individual's had COVID-19 infection? Actually, I have a nephew who's a surgical fellow up in Hackensack, and he got vaccinated yesterday, and he had COVID-19 in the spring. Essentially, individuals who've had COVID-19 in clinical disease or documented disease should be offered the vaccine. And so regardless of their history, they should get it. And they don't need to be tested in advance to see whether they've had it before if they've not had clinical disease. We know that COVID-19 can cause asymptomatic infection in individuals, but that doesn't mean people need to go out and get tested for COVID-19 beforehand. Whether you've had it or not, you can get it. Next slide, please. And if they have current disease, clearly getting the vaccine is not going to help them, because with current disease, they're going to be sick, they may have a fever. The last thing you want to do is give them a vaccine that might cause them to have adverse events because of the vaccine itself, and it won't help them. Their body's already mounting an immunologic response, and the vaccine's not going to supplement that or add to it. So when should they get it after they've had acute disease? Well, there's no minimal interval, but certainly they want to get past the symptomatic period, probably at least a couple of weeks. And in addition, the data that has been produced now, through the 9 months of the pandemic, 9 or 10 months, is that reinfection can occur, but it doesn't occur very frequently, and certainly not in the first 3 months after acute disease. So people who've had COVID-19 should consider waiting at least 90 days after they've recovered from their disease before they come in and get the vaccines. It's not a requirement. It's just essentially something that they should consider, and they should consider this in conjunction with discussing it with their healthcare provider. Next slide, please. Some individuals who've had COVID-19 in the last month or so may have gotten passive antibody, the monoclonal antibody. Has become available also through emergency use authorization, either the Lilly product or the Regeneron product. And again, if there's no data to basically indicate what role or when vaccination should be given to those individuals. But you don't want to be giving vaccine to an individual where they've just been given a monoclonal, because the monoclonal might interfere with the immune response that you'd expect from the vaccine. So again, deferring vaccination until at least 90 days after receiving a monoclonal for the treatment of COVID-19 would be advised. Next slide, please. What about if they've had exposure? Well, again, if they're in a quarantine period and they don't know whether they're incubating, where they've been infected and they're incubating the virus and they're about to become sick, now's not the time to vaccinate them. They're just going to have to wait out their quarantine period. If they get sick, then they'll be eligible for remdesivir as a treatment and the monoclonal antibodies as well. If they're a resident of a congregate setting, there's a fair amount of exposure going on in those facilities. And it's unlikely that there'll be additional exposure that they might get. And so from healthcare providers or others. And so in fact, it's probably appropriate for them to get vaccinated, because there are good infection control, prevention and control processes and standard operating procedures in these long-term care facilities. And this is true also for residents of other congregate settings. Next slide, please. Next slide. So special populations. Well, in both clinical trials, people with underlying chronic conditions were studied, people with chronic heart disease, lung disease, diabetes, obesity, and other diseases as well. As I mentioned earlier, vaccine efficacy seemed to be the same in these groups, so they didn't have an impairment of their immunologic response, even though they had underlying medical conditions. Now, these are traditionally, we're talking about non-immune compromised individuals. I'll get to that in a minute. And as I said, it seemed to be that the safety and efficacy profiles were similar in these people who were in any one of these who had any one of these underlying conditions that I mentioned. And of course, these individuals are at increased risk for getting COVID-19 and having severe disease. So these individuals will be considered in phase 1C. When we get to that, right now we're in phase 1A. Healthcare workers and long-term care facility residents are the ones who are eligible for the available vaccine. Phase 1B will be essential workers, and we're working on determining who those might be. And phase 1C will be individuals who are over the age of 65 or have underlying chronic disease. Next slide, please. So what about immune-compromised persons? The Mrna trial had no individuals who might be considered immune-compromised. The Pfizer clinical trial had some people who had HIV infection, hepatitis B or hepatitis C, but these were people who were stable with those underlying conditions. So there really isn't good data available for the use of vaccines in immune-compromised patients, either on safety or on efficacy. Now, the clinical guidance, the FDA EUA doesn't prohibit these individuals getting vaccinated. There's no contraindication in the EUA on that. And the CDC clinical guidance is that these people could be considered for vaccination with either one of these products. Well, we don't know yet about the Mrna product, but I'm assuming that they're going to say the same. But they should have a conversation with their healthcare provider about that. We really don't know what kind of immunologic response they're going to have to this because they're immune compromised. So we really don't know what kind of protection they're going to have after being vaccinated with either one of these vaccines. Next slide, please. Now, pregnant women, this is a very frequent question. I have two sets of slides here, not two sets of recommendations, but recommendations from different bodies. I have it from the CDC, and I also put in there recommendations from the American College of Obstetricians and Gynecologists, a clearly important professional organization that has weighed in on this. So pregnant women, again, these individuals were excluded from the trials, although there were a few pregnant women that made it into the trial because they became pregnant potentially between the first and second dose, or they didn't know they were pregnant before they got the first dose. I don't think that they were tested for pregnancy before the trial began. There are mRNA vaccines. These are not live vaccines. I want to reiterate, these are not live vaccines. It's only a piece of genetic code. And this genetic code is degraded very quickly when it's injected into the body. Within 48 hours, it's basically gone. We know that pregnant women are at increased risk for COVID-19 and for getting severe illness, just like they are when they get influenza. And as you know, influenza vaccine is recommended for pregnant women. And so there might be an increased risk of adverse pregnant outcomes with COVID-19, such as preterm birth. And of course, pregnant women are younger and they're much more likely to be part of the healthcare workforce and taking care of individuals in congregate settings, for example. So they also are in jobs where they may have increased risk. And so the recommendation and the guidance is that pregnant women are eligible to get vaccinated, but they should discuss this with their healthcare provider. Next. These are the considerations when they have that discussion. What's the level of community transmission? So there's a lot of if there's a lot of virus circulating in the community, it puts them more at risk. What's their personal risk? Because of for example, their occupation or their activities. They need to talk about potential risk for the fetus, although there's no data to indicate right now to date that there's a fetal risk. As again, the mRNA is not expected to be cross the placental barrier. The efficacy of the vaccine is obviously quite high. We know what the side effects are. And again, we don't really have data in pregnancy. So this really needs to be a conversation between the woman or the woman and her family, her significant other, and their provider. They can take acetaminophen if they get fever after the vaccine. They need to come back for the second dose. And routine testing for pregnancy is not recommended before getting vaccinated. Next. And then out of the American College of Obstetricians and Gynecologists, they have published a practice advisory. The link to that statement is at the bottom of the slide. And I just want to basically say that their recommendation is the same. That the COVID-19 vaccine should not be withheld from pregnant women, and they should discuss it with their providers. Next. Lactating women or breastfeeding women, same recommendation. There's no reason to be concerned about transmission of the mRNA across the through breast milk. As I said, mRNA is degraded very quickly, and there is no expected risk to the newborn. Next. And same statement from the American College of Obstetrics and Gynecologists. And again, the first couple of slides were from the CDC. Next slide. Next slide. I just want to very quickly, because I think I'm going on a little bit too long here. And bottom line is we want people to come back for the second dose. So they need to be counseled on what to expect with the first dose. And so this is important. I mentioned the level of adverse events, mostly local injection site reactions, and there are some systemic adverse events as well. And again, mostly mild to moderate, but you need to let people know what to expect, or they'll think maybe they're getting sick with COVID-19. You cannot get COVID-19 from these vaccines. I repeat, you cannot get COVID-19 from these vaccines. And unless they have some contraindication, they should complete the series. And they can use antipyretics or analgesic medications for post-vaccine symptoms or signs. Next. Despite getting vaccinated, and even when you have both vaccines, both doses rather, it's not 100% effective or efficacious. And there's a lot of virus circulating in the community. So you may not be 100% protected. It's great efficacy, but everyone is going to continue to basically practice the non-pharmaceutical interventions that have been keeping many of us who've been following those interventions safe, such as wearing a mask, social distancing, avoiding crowds, washing your hands as often as you can with soap or water or antibacterial Purell, quarantine guidance if you've been exposed, and so on. Those are going to continue to be required until public health officials say we no longer have to do that. And that's only going to happen when a high percentage of the population is vaccinated, and we can count on either direct protection from the vaccine or community protection through indirect protection from the large number of people who've been vaccinated, what we call herd immunity. Next slide. Contraindications and precautions, you've heard about. Next slide, please, sorry. We heard about the anaphylactic reactions of the folks in the UK. There've been a couple here in the US. In these cases, several of these individuals had a history of actually having allergic reactions. And it underscores the importance that when individuals get vaccinated, they need to hang around for at least 15 minutes to be observed. And they've actually had anaphylactic reactions from other products in the past, not necessarily this product, that need to be observed for 30 minutes. Go to the next slide, please. Maybe if we can enlarge it a little bit, or maybe I need my glasses to see this. That's better. So let's focus in on the bottom aspect of this slide. This is the algorithm for triaging of people when you're considering vaccinating them. And again, it's labeled for Pfizer COVID-19 vaccine. I'm sure it'll be the same for Moderna. But you can see on the left is green, which means go. On the right means red, which means no go. Green. So if you have a person's had a history of allergies to food or pets or insects or latex, or they've had a history of allergy to oral medications such as penicillin, or a non-serious allergy to vaccines or other injectables, they can get the vaccine. They have to be observed for 50 minutes. If you're in the yellow column, a history of severe allergic reaction to another vaccine, not the Pfizer vaccine, not the Mrna vaccine, or they have a severe allergic reaction history to other injectable medications, there needs to be a discussion with their healthcare provider. Maybe they defer it, depending on issues like how much virus is circulating in the community. But if they do get vaccinated, they need to be observed for 30 minutes. And this is true in any points of dispensing, whether it's a clinic, a FQHC, a pharmacy, a large mass vaccination program. this is the same recommendation anywhere. And then, of course, if they've had an allergic reaction to the anaphylactic allergic reaction to the first dose of the COVID or Mrna vaccine, they can't get the second dose. Next slide. Interpretation of test results. Next slide, please. So viral tests, if you've had, getting the vaccine will not impact on testing, whether you're using PCR or an antigen test. Antibody tests will be impacted because the vaccines are going to cause an, antibody formation, neutralizing antibodies specifically. So if somebody's going to be getting an antibody test, it can't be the regular neutralizing antibody test. It has to be a test for the N nucleocapsid protein. And a lot of those tests are specialized tests. There has to be a good reason to get an antibody test after you've been vaccinated. There's no need to do it unless someone is ill with COVID-like symptoms, and then it might be appropriate to do that. Next slide, please. I'm done. I think the next few slides are just clinical resources that are available at the CD site. There are tons of resources that are available on the New Jersey Department of Health website, and those can be provided after this presentation. So thank you for that. And I'll take some questions afterwards. Maybe we'll let Rebecca present, and then we can get into questions if that's okay, Mary.
Yeah, thank you so much, Dr. Bresniff. Excellent information, and we've made it a point of addressing in the questions that have come in. These slides will be available along with the recording, hopefully shortly after our presentation today. So thank you so much. Again, great content. Today, we're also joined by Ms. Rebecca Werble, the lead for the vaccine points of distribution, or pods, within the state, who will be discussing the patient journey at the point of dispensing. So Ms. Werble, welcome. Thank you for being with us. Rebecca, if you could just unmute.
Yep.
Perfect.
I was like, I knew something was missing. So almost good afternoon to everyone. Thank you for having me here today. As you said, my name is Rebecca Werble. I am with the Office of Disaster Resilience within the Department of Health at the state of New Jersey. And I am the co-chair for the working group on pods, points of dispensing, and logistics. I think if whomever has the slides, I think we're on slide 10. So while we're getting to the slide, I'll just talk a little bit about what a pod is. We sort of throw that term around every day, many times a day, many times an hour at the State Health Department. A pod is a point of dispensing, and this is essentially a vaccination clinic. Why we call it a point of dispensing is because it looks a little bit different than when you would typically get a vaccine. When you would typically have a vaccine administered. So a points of dispensing can take many different shapes and forms. And when we get the slides up, I will tell you a little bit about what those shapes and forms do, what they look like. While that's happening, I mean, the other piece of the puzzle that the logistics work group looks at is really at the state level amongst all of the pods and amongst the distribution network about what are the logistical needs. So there's a lot of coordination that we are doing with our state partners at the New Jersey State Police and the Office of Emergency Management and Homeland Security, as well as with the Board of Public Utilities and the Department of Transportation with our first wave of Pfizer vaccine coming in the middle of a snowstorm that presented some logistical challenges for us. So that's another component that we work on the logistics team.
Hi, Rebecca. I'm just working on getting your slides up. Just give me 1 second, please.
Okay, thank you. Okay. Okay.
Thanks for bearing with us. We're good, I think.
Oh, no, thank you for putting the slides up. I really appreciate that. So,
Oh, Rebecca,
as
we lost your audio.
oh, is it better now?
I hear it.
I can hear you, Rebecca.
I can hear you, Rebecca, too. Go ahead.
Okay, thank you, Dr. Bresnitz. And
Rebecca,
thank you,
I'm going
Dr.
to ask if
Bresnitz.
you could just join us via the phone link.
Okay, where can I find that?
Hi, Mary. I believe that you might have a connection issue. I hear Rebecca and Dr. Bresnitz.
Yeah,
Can
go
you
ahead.
hear me okay?
Yeah. I can hear you, Rebecca.
Oh, all right, we're good. Thank you. Sorry.
Okay, that's okay. My Wi-Fi has been a little glitchy today, so let me know. Okay, so the patient journey at a point of dispensing, as I mentioned, the point of dispensing is, which we call affectionately pods at the health department, are the different clinic locations where people will receive the COVID vaccine. This is a term and a function that we've used throughout the past, I would say, decades at this point in the public health field, whenever we are doing any sort of public health emergency vaccination. We use them during H1N1 and other situations such as that. So the patient journey, it's actually a fairly standard when you think about how you process through your healthcare visits these days. There will be a pre-registration and education. Because there will be so many people coming to these pods, and because of the public health restrictions that we have right now, we really are hoping that most of the patients will be pre-registering and pre-screening for the pod location. So that would include the pre-screening for eligibility. So a patient would do the pre-screening and receive some education. They may or may not at that point in the pre-screening receive the EUA. Dr. Bresnitz will correct me if I say it the wrong way. It's not a vaccine information sheet because it's under an EUA, but I believe it's called a patient fact sheet or a patient information sheet that you would receive with the specifics of the vaccine. Once that pre-registration is complete, and then you would then obviously show up to the clinic for your appointment, there will be another level of registration. At this point, there is no written consent required by the CDC for this vaccine. It says TBD because things are fluid and changing, and different facilities may have different requirements surrounding that. The vaccine, obviously, the vaccine is administered, and the observation and follow-up period is incredibly important. I know Dr. Bresnitz talked about the difference between the 15-minute and the 30-minute observation period for a certain subset of people. As our medical directors, Dr. Bresnitz and Dr. Montana at the department say, this 15 minutes of post-observation is actually recommended for all vaccines, not just COVID-19. So that is something that will happen at all of the pod sites. It will be done in a socially distant manner with adherence to all of the public health restrictions and guidelines that are in place. Once that 15 minutes is over, each person will receive a vaccination card, and they'll receive safety information and details details for adverse event reporting, as well as the all-important second dose reminder. Next slide, please. So this is an example. The first slide was an example of a standard walk-in clinic. This is an example of a drive-through COVID-19 vaccination site, or any vaccination site really. There will be some drive-through sites in the state. It will vary depending on where you go, and the pre-registration would be exactly the same. The registration, the clinic staff, the pod staff would come to you at your vehicle. The vaccination would happen while the patient remains in the car. There may be 1 or 2 vaccinators if they're depending on how many people are in the car and the staffing of the pod site. And then the observation would happen in a parking area where the patients would, after they receive their vaccine, would be parked stationary for 15 minutes, and there would be staff moving around to observe them. And then the follow-up would be the same in terms of administering the vaccination cards and the second dose reminders and any further education pieces. Next slide, please. So we have a few different types of pods that are classified by size. Not every one of our pods fits neatly into one of these size categories, but the largest one that we have is called a mega site. At a mega site, it's called a mega because we expect up to 2,400 doses a day that these sites will be able to process that. So with as many as 20 lanes of 20, and a lane referring to, from beginning to end during the registration, the vaccination, and all the way through to the observation and follow-up. So these mega sites will be scalable so that they can contract and expand based on the supply and the demand, including what other pod sites are stood up in the surrounding areas. But we do expect them to be able to vaccinate up to 2,400 a day. This slide goes into a little bit the different pod sites that you might see, or as you are healthcare providers, where you might be working. The different greeters and patient navigators, just to point out that the patient navigator is a really important piece of this puzzle, and that we want to make sure that patients, that all people that come to these pods are able to get through the system, understand the registration, understand the whole process, and get all of their questions answered. So that's a key component at each one of our pod sites. There are obviously the vaccinators. There will be at the bigger sites, the mega sites, there will likely be 2 vaccinators per lane, whereas at some of the smaller sites, you would see 1 vaccinator per lane. And you would also, at the mega sites, you would see data entry staff and runners that would be assisting at that vaccination station, and they may be trading off. They would all be similarly able to administer the vaccination, and then can rotate through the different positions. And then the observation staff, obviously, for each lane. There will be site-wide staffing, and the site-wide staffing almost always remains the same regardless of the site size. So obviously we're going to have security at each one of these sites, medical screening, volunteers. Each site is required to have a vaccine coordinator. That's a requirement of the CDC provider agreement to be a COVID-19 provider, and that is different from the clinic manager. The vaccine coordinator is not necessarily a clinician, but maybe. We will have safety. The EMTs will not be on site at every pod. Some of the mega sites may have EMTs on site, but they won't be at the smaller ones. We need to plan for float and relief staff. And then we'll also have some on-call off-site staff that will be serving multiple sites, whether that be IT and data management, translations, maintenance, and appointments. Next slide, please. So the next step down from the mega site is a large site. The large sites have between about 300 and 500 doses per day. Sorry, the slide says something a little bit different, but I think that I'll double check on the slide, because they have about 300 doses per day to 500 doses per day. Sites that you might see here in this large site range, you might see some of the county health departments, the local health departments that would have sites that are this large. You'll see some of we have a few university partnerships that will be standing up sites at some of that will be standing up sites on their campuses, and those you would see that would fall into this large category. Some of the hospitals will be expanding into community-based healthcare workers, and or further expanding into other populations in the community. And some of those you might see that would fall into this large site. I don't think I mentioned it with the mega site. The mega sites will be state-run sites. They will be state-run, and they will be done in partnership with local partners, whether that be public and private local partners. So mega sites are state-run, and then the large sites and other sites are run by independent public and private partners. And you can see the staff here virtually stays the same. It's just degrees of the degrees of how many that we have. So I won't run through all of that again. And so next slide, please, for the medium. All right, so the medium sites, again, the main difference here is the staffing in terms of the dedicated staffing per lane, that where we're down to one vaccinator and, we don't have a runner in this one. And in terms of the throughput, we're talking about 50 to 100 doses a day, with about 300 to 600 doses per week. The sites that you might see here in the medium category would be FQHCs, federally qualified health centers. Some of the retail pharmacies, some of the larger retail pharmacies will be in this medium category, as well as some primary care and larger urgent care groups would be in this category. Next slide, please. And the microsites. So microsites have about 30, we estimate about 30 doses a day for a microsite. And that these are really the sites that are administering the vaccine largely as part of their routine practice and not setting up a separate clinic for this. So any of the sites that I discussed could fall into this category, whether that be a private clinician's office, it could be an FQHC, it could be an urgent care, it could be a pharmacy. Some of the local health departments may transition to this or may start off on this. One of the pieces about the pod network and in the design of the pod network is that we've designed it to be scalable so that we can expand and contract based on the supply and demand, as I mentioned with the mega sites. So as things evolve, you might see one site that transitions from a micro site to a medium site to a large site and back down. So this is, if it hasn't been said yet in this particular presentation, the science is getting clearer and clearer as Dr. Bresniff's laid out, but some of the planning assumptions can remain fluid and dynamic. And so as we are moving forward with our planning, that's a really key component in that we have these scalable and flexible plans. And as you go through the state, you'll see things will be set up differently. The way that New Jersey is set up, really the jurisdictions, the municipalities and the locals and the counties, they really have the flexibility because there's the need to set things up designed to specific to the unique needs of those communities. I know that we've had a number of questions in the Q&A about how will healthcare workers know where to get their vaccine if they are not affiliated with a hospital. I can say that a number of the pod sites that I sort of listed off will be open to community-based healthcare workers in the coming weeks, and that we are in the process of rolling out a statewide system that would direct community-based healthcare workers and then moving forward into the other target populations to the sites that are open to their population and geographically manageable for you. Next slide, please. So here we really wanted to emphasize the second dose, the second dose communications is what this is talking about, but just really the importance of that second dose whenever we are talking to our pod sites and setting them up. It's a mutual question that the state has for them and that they have for us in terms of what are we doing about the second dose to make sure that people get back for the second dose. So as you can see here, there are 10 channels that we have planned for both generating awareness about the second dose and the importance of the second dose, as well as targeted reminders. I won't talk through all of them because I think that everybody can see the slide, but just to highlight a few things that, number 4 with pods on-site communications, every clinic will be providing second dose reminders as part of their processes. They will do it as the person leaves from the first dose, and they will do it as the second dose appointment is coming on board. Number 1, NJVSS, that talks to the statewide system that I just referenced in terms of pairing up people that are ready to be vaccinated with a vaccination site or a pod site. That will have automated text and email reminders. And then individual pods will have their own reminders as well. We are looking at a comprehensive public awareness campaign that will talk about every aspect of the COVID-19 vaccination and the importance of that in order to build public confidence, as well as the second dose reminder. We'll be reaching out at sort of the statewide or the large organizational level for doing group-based broadcasts, whether that is through a union or whether that is through the Medical Society of New Jersey, and we'll be doing things that way. The other one that I wanted to pull out on here to mention is number 10 is the COVID Education Corps. And what that is a group of people that are being recruited that will be working with, excuse me, sorry. Got sidetracked by a text for a second. That the COVID Education Corps will be working directly with communities, in particular vulnerable populations, to help them navigate this system. There definitely will be some, there may be some IT components to this, and that Education Corps will be advocating for these populations and making sure that if there are pockets of groups or even individuals that need assistance to get into this vaccination process, and with the follow-ups, with the second dose reminders, and managing all of the different steps, and really the overwhelming amount of information in this area, that's what that Education Corps is for. So I think with that, I think that's my last slide.
Excellent. Thank you so much, Rebecca. And again, wonderful information. We really appreciate your perspective and being with us. I have a few questions, but I want to come back and I just want to recap what we heard from Dr. Bresniff. We have about 15 minutes or so for questions and answers. And I've tried to sort of curate the things that we were seeing coming in from the chat and also from some of our pre-submitted questions. So Dr. Bresniff, I was just wondering if you can sort of recap for us COVID status before receiving the vaccine. So here's what I heard. I heard no COVID test before becoming immunized, waiting 90 days after recovery from COVID before receiving your vaccine, 90 days after the monoclonal antibody treatment for COVID. What if an individual contracts COVID between those two doses of the vaccine?
Well, which is possible because they may have been exposed before that first dose and they're incubating virus, and the vaccine, the first dose, doesn't prompt a immunologic response fast enough to basically prevent viral replication and disease. Obviously, if they develop symptoms, and of course, some of the symptoms are going to overlap, right, between the vaccine and getting infected with the virus, particularly the systemic reactions, such as fever and chills and muscle aches and so on. And so that's going to require some clinical diagnostic acumen to differentiate disease from the vaccine. Clearly, if a person develops the specific symptoms of lack of smell and taste, which are not the kind of things that you would expect with the vaccine, and not the kind of things you would expect with flu infection either. And this is a good opportunity to say, if you haven't gotten the flu shot yet, please go get the flu shot. The flu season, so far, it's been almost non-existent, probably because there's a lot of social distancing and mask wearing, but the flu season can still happen. So please, let's get vaccinated, and then we don't have to worry about that a little bit less. So that's the answer to that. By the way, coming back to the 90 days about when you've had disease, it's not necessarily that it's recommended, it's that they should have a conversation with their doctor. They can consider waiting 90 days. I don't want to say that the CDC actually recommended that. There were other few questions, if I could very quickly also glance through, if I could just get to them, and that have to do with the disease. Somebody asked about whether you have a history of blood clots, whether you can get it or not. Well, if you've got a bleeding diathesis or a bleeding condition, the major issue is actually the injection with the needle, not so much the vaccine itself. So that's really the issue that you need to be conscious of, is that when you put something into your muscle that's an injection, you could cause a blood clot there, but otherwise there's no indication that the vaccine itself can cause blood clot. Question about allergy shots. That again, you probably don't want to get it during the time that you're getting your vaccine. And I would say that 2 weeks before and 2 weeks after is probably appropriate, but the CDC hasn't weighed in on that. Just makes sense. Autoimmune diseases, they weren't studied in either of these trials. So the recommendations or guidance is that you have an autoimmune disease and you're non-immunosuppressant, have a conversation with your healthcare provider about that. Guillain-Barre Syndrome. Guillain-Barre actually is something that's personal. My son had Guillain-Barre a number of years ago, and I'm going to advise him to get vaccinated because there's no indication that these vaccines cause Guillain-Barre syndrome. Fertility, question about whether it had impact on fertility. No indication that his had impact on fertility whatsoever. And remember what I said, the mRNA virus doesn't cross the blood placental barrier. It's broken down within 48 days. and mRNA is not incorporated into the nucleus. So fertility is not, impacting on fertility is not an issue. And finally, somebody asked me about why I was saying that people should avoid getting pregnant. I think that maybe I misspoke. It's that people shouldn't need to get tested for pregnancy before they get vaccinated. That's really the recommendation. Over.
I think that's a really excellent point there also. Let me ask you, I did hear you speak about managing post-injection site reactions and symptoms with analgesics and antipyretics. Should pre-medication with acetaminophen or NSAIDs be recommended before someone receives the vaccine?
CDC guidance doesn't recommend that.
Great. Rebecca, we had some questions about the pods and the distribution process. And I think one of the questions I saw was, will all these different distribution centers have EpiPens available and be equipped to manage an emergency should an allergic reaction occur?
Yeah, so there will be, actually, I don't know if Dr. Bresniff has more information on this, but the CDC just recently put out some guidelines about how to treat the anaphylaxis reactions so there are specific guidelines, and I can provide the website to you so you can look through what the CDC guidelines are for that for all of the pod sites, but the pod sites will follow the CDC guidelines, and I believe an EpiPen is one of the minimum things on that list that they have to have.
Sure, I was always taught as an immunizer, if you don't have the EpiPen, don't immunize. So
yeah, the guidance or the requirement will be that the providers are ready to manage an anaphylactic. They need to be ready to manage an anaphylactic reaction.
Great. Can you talk a little bit where the vaccine ingredient list or excipient list can be found?
Yeah, those slides that I had, which were comparing the two vaccines, I had that on originally, but then I took it off. There is a list that they're very long technical chemical names. You can go to the go to the FDA website, click on the VRBPAC meeting. You'll see the briefing documents that were submitted by both manufacturers for both vaccines. These are long documents. And the data should be in those particular documents as well.
Eddie, I included that link in an answer to the question, so it should be in there.
Great. Thank you.
There were some other questions about the vaccine itself, if I could just take a minute. Pediatric use, not under the age of 16. The manufacturers will be doing pediatric studies moving forward. There are why are there different storage requirements? Well, as I mentioned right at the beginning of my presentation, these mRNAs are unstable, and they're basically placed in an envelope of a lipid nanoparticle. They're not exactly the same for both vaccines. They require different handling, and so that's why there are different storage requirements for these two vaccines. Somebody asked about, well, will the second dose be available? The CDC and the federal government is putting aside those second doses. So when they're providing doses to the state, if they're providing X number of doses, then they're also setting aside X number of doses that they'll provide to the state within 3 weeks when the state requests them. Someone asked, when will this go from a EUA to a licensed vaccine or a biological license application needs to be submitted by both manufacturers. They need to have at least 6 months of follow-up of safety before they can actually submit a biologics license application. So it won't be until probably late spring, early summer when you might see an actual full licensure of either one of these vaccines. Will there be choice for either one of these vaccines? Can a potential vaccinee choose the vaccines? Probably not. Because most institutions will probably receive one vaccine or the other. Some cases they may receive both, but it really depends on what's available. And there's really no basic difference between the two vaccines. And so frankly, I don't think it would make a difference choosing one or other. Now, future vaccines, that might be a single dose with different efficacy, a different safety profile, that might be a different story, but we don't see anything on the immediate horizon for getting a third vaccine out there. And finally, people were asking why are there more doses in the vial? You know, there's supposed to be 5-dose vials and those Pfizer vials that are reconstituted. Well, the reconstitution requires a certain volume of saline. And when you inject that volume into the vial that's been thawed, it turns out that there is 2.5 milliliters of fluid. and each of the injections is 0.3 mils. So when you divide 0.3 into 2.5, you actually can get up to 8 doses, although it's not possible. Remember, when you draw the volume up from the vial, some of it stays in the needle and in the end of the syringe. So you can't really pull up everything that's in there into the for injection. So up to 7 doses, probably more like 6, and it's basically labeled as 5.
And I think an important point, because at least with the Pfizer product, preservative free, so not combining, extra or overfill from the different vials is also something that I've seen.
Go ahead.
Go ahead,
No,
Dr.
well, there were some questions about, when am I eligible? And without answering the specific questions, there's a phase 1, a phase 2, and a phase 3. A phase 1 we're in phase 1 right now, but phase 1 is divided into A, B, and C, which I mentioned earlier. I'll repeat those. For A, if you're a healthcare provider, whether you're paid or unpaid, whether you're working or living in the state or a student, you'll be eligible. It doesn't make a difference what setting you're in. Right now, we're focused on the hospitals because we only have limited vaccine. And from a logistics perspective, that's where we started. Rebecca mentioned those other points of dispensing that will be set up when we get more vaccine, and healthcare providers, paid or unpaid, volunteer or not, students, whatever, they will be eligible, assuming that they're healthcare workers and having frontline exposure, potential exposure to people, they'll be eligible to get vaccinated ultimately in one of those pods. Phase 1B is essential workers. We're working on that list right now. There are a lot of essential workers in the state, and the Professional Advisory Committee is deliberating right now. And phase 1C is people with underlying chronic medical conditions with and over the age of 65. Phase 2 is basically when we start to open it up to other folks, where we think that supply and demand will be approximately equal. And then phase 3 is when we have much more supply than we have demand. And we're expecting to reach that probably, hopefully, by the summertime.
Great. Rebecca, just as we conclude our session, I have 2 final questions, a little bit about the logistics of the pods. Do both doses of the vaccine need to be given at the same pod?
So that's an interesting question. And actually, we're working through that right now. As Dr. Bresniff said, you are supposed to, the products are not interchangeable. Right now, we are advising that people would go back to the same pod for that, in part because of what Dr. Bresniff had said, because the second dose is being held back by the federal government, though that first and second dose are linked logistically. So as of now, we're advising that, yes, you would need to go back to the same pod to get it. We will need to, I think, consider as we move forward, what happens if somebody moves in from out of state. And I know that, with other vaccinations, you can start a series in one place and then finish the series in another place. So we have to look at that as we move forward. But as of now, yes, the expectation would be that you go back to the same location, the same pod for the second dose.
Great. And is there a standard consent form that should be utilized?
Again, Dr. Bresniff, please correct me if I'm wrong, but right now there is no required consent form from CDC to receive this vaccine.
That's just to qualify, there's no requirement for a signed consent. There is a requirement that the provider provide to the potential vaccinee the FDA approved patient information fact sheet, which takes the place of the vaccine information fact sheet that is normally handed out when you get vaccinated with a licensed vaccine. So for example, if you go to the pharmacy or provider, you get a flu shot, they usually give you a piece of paper that talks about the vaccine, its benefits, its risks, and so on, and some other information. As a condition of the EUA, the manufacturer was required to produce or develop both a provider information fact sheet and a patient information fact sheet. The provider one is much more technical, as you can imagine. The one for patients, unfortunately, is, in my opinion, is a bit long. It's like 6 pages long, and some of the language is a little bit more technical. But I understand the CDC is going to provide maybe a little bit more simplified information sheet that probably could be handed out, but it has to be in conjunction with the fact sheet. The fact sheet the EUA fact sheet has to be given to the patient.
Right. And just final word on this. So does receipt of the vaccine mean that our masks and our social distancing and hand hygiene, does that all go away?
No, no, and no.
Thank you. I appreciate those remarks. I think that's an important message to end our session on today. Thank you so much to everyone for attending and participating in today's session. We have recorded our remarks, and these will be available on the Rutgers Project Echo website as soon as, hopefully before the end of the day, or certainly by this weekend. Our final session of this special series addressing the long-term care pharmacy partnership will take place this coming Monday, December 21st at 11:15 a.m. Please be sure to register and join us at this time. Thank you so much to Dr. Bresniff, Ms. Wirbel, and Dr. Fisher. Have a wonderful day, everyone. Happy Friday.
Bye, everyone. Stay safe.
Take care.
Bye-bye, thanks.